Okay, now we're recording. Right? What is the way through which you go in this exam? Like, what is the approach that you have? Right? You always have to start by looking at the question, right? What is the question? All because this is the standard length of the question that you would have on your exam day. Now you see how many sentences there are. There are around let's see, 1, 2, 3, 4, 5, 6, 7, 7 sentences, right? This is the standard length of the question that you might see on your exam. And when you're going to do plabable, it's just the opposite. You would just see 3 or 4 sentences, and that's what your brain gets to think, that that on your exam also you're going to have such kind of lengthy questions. But that's not true. You have large or a lengthy stem of a question, right? So it is good that you start with medrevisions. Let's without talking further, let's move ahead. So how do you begin? You're always going to start by reading the question. This one says, I'm hoping the screen is very visible, clear, and you guys can see it properly, because you're going to answer this, right? I don't care if you've just started. I don't care if you've forgotten all your medicine. You are going to participate and answer. If any of you who have paid or not, right? If you do not answer, you will not be allowed in a meeting, right? I'm very strict about it, and I would return your money. Okay, so I'm hoping you guys are seeing this properly and do hear me properly. Let's begin. This one says, what's the single most appropriate investigation that will lead to a diagnosis? Now read the question very carefully, because this is everything. The last sentence of your question is everything. This one says, what's the single most appropriate investigation that will lead to diagnosis? So is it asking about the diagnosis, or is it asking about the investigation? You guys have to type it and answer through that. So what is it asking? Is it asking about the investigation or the diagnosis? It's asking about the investigation, right? After you read this and you know that they're asking about the investigation, then you move from here upwards, right? Like you start from below, then you go up. This one says, on auscultation, an ejection systolic murmur was noted around the second intercostal space at the right sternal border. Now, when they say ejection systolic murmur, can you guys tell me where or which heart valve conditions would have an ejection systolic murmur? You all are doctors. Some of you may have forgotten your medicine. Some of you don't even remember it, or it's been a very, very long time. But still, you have to tell which of the following is the one where you have your ejection systolic murmur. All right, let me give you options. AS, aortic stenosis, aortic regurgitation, mitral restenosis, right? And pulmonary stenosis. Okay, aortic stenosis, another one. Where else do you have an ejection systolic murmur? Okay, AS, and where else do we have our ejection systolic murmur? All right, PS, pulmonary stenosis, right? Okay, now this you have to remember. I would want you to prepare a page, right? Or from your notebook, a part of your notebook, and dedicate it just to the murmurs, right? That is it, nothing else but the murmurs, right? So write ejection systolic murmur, and in front of it, write PS and AS, right? Now, when it is a murmur, for a murmur, do you do an ECG or echocardiogram? How would you define it? When we hear a murmur, is it a morphological problem of the heart or a rhythm problem of the heart? A murmur is a morphological problem of the heart or a rhythm problem of the heart? Like, does it involve the structure of the heart as a whole, or the rhythm that goes through it, the electrical current? Think about it before you answer. Think about it. It's morphological, right? Murmur happens when there is a stenosis, right? That means that the heart valve, it just closes, right? It just closes, or it is not working properly. So it's a structural problem. For a structural problem, do you think you should do an ECG? Because ECG is also like an EEG, right? Can you see the screen? ECG is also like an EEG, which is electroencephalogram. You do that to catch the rhythms in the brain. You do the ECG to catch the rhythm in the heart. Echocardiogram, on the other hand, is done to catch the morphological problems. So here, what would you do? An ECG or an echo? We've not read the rest of the question, but we're just trying to answer from this one. So it says that they're asking for the investigation, and the person has an ejection systolic murmur. What would you do? An echo or an ECG? You're right, it would be an echo. But before we go here, let's move up and see how else do we remember it, right? So in ejection systolic murmur, the person is noted to have a blood pressure, right? That has been reducing, right? Obviously, because his heart's not working, so it's going to be a reducing murmur, like reducing blood pressure. On examination, his pulse is normal, respiratory rate is this much, right? Blood pressure is also normal. On further questioning, he mentions that he feels short of breath along with a mild chest pain even if he walks a short distance. What does that show? What does that show? When he walks a small distance, he has chest pain. Is that angina? Seems like that. Does it? Almost, right? Maybe could be angina. Now, either if you start from here, which is the last sentence, or if you start from the first sentence. Now, you know, most of the candidates, what they do is they start from the first sentence. Let's go to the first sentence and see how we can get the answer. This says a man working in a garden who suddenly collapsed was taken to the emergency department, right? He lost consciousness only a few seconds, and this is a third time he has similar symptoms. Now, we do not know the age of the man, but we do know that, you know, he suddenly collapsed when he was walking, right? When he was doing work in the garden. Now, these kind of situations, and if they told us that he was 80 years old, then remember, this is a clincher for you guys. Clinchers are the ones that are going to help you pass the exam and help you understand how to get to the answer faster. If there is an old man, they collapse, they have loss of consciousness, we're immediately thinking of aortic stenosis, right? Old men, so for aortic stenosis, your notes are old, collapse, loss of consciousness multiple times in a week, right? And ejection systolic murmur. That would immediately make you think of what? Aortic stenosis, right? Let's see if that is a correct answer. Okay, echocardiogram, right? Now let's move to the next question. I'll only be reading the notes when I think it's absolutely necessary for you to understand. Are you guys following? Do all of you understand? Really important that you do understand. This has been recorded and this is the trial class. After this, you're not going to get any trials. I'm hoping you guys understand. Let's keep on moving, right? So this one says, what will be the arterial blood gas most likely to show? What will the arterial blood gas most likely show? Now, here it says the CT pulmonary angiogram reveals a right-sided pulmonary embolus. Now, first question here is, when we're having pulmonary embolism, is it a respiratory issue or a metabolic issue? When you have pulmonary embolism, is it essentially a metabolic issue or a respiratory issue? It's a respiratory issue. I want all of you to answer because I'll be calling out names otherwise, right? Okay. It is a respiratory issue, right? Dr. Divya, Dr. Hamza, Dr. Eskel, Dr. Haskam, all of you guys, Dr. Maharos, right? Okay, this is a respiratory issue, and this is not a metabolic issue. That's number one. All right. In respiratory issues, if you have shortness of breath, right? If you have shortness of breath, what happens? If you have shortness of breath, do you have a buildup of carbon dioxide or you have an evacuation of carbon dioxide? When you have shortness of breath, what happens? If you're short of breath, okay, and if there's a buildup of carbon dioxide, if you guys are saying, then what would be the answer here? First of all, you guys said it's not a metabolic problem. So option 4 and option 5 are out of the window because we're talking about pulmonary embolism, right? So these are out of the window. If that happens, right, these both are out of the window. So we have got mixed respiratory metabolic. This one is also incorrect because we're thinking it's not metabolic. So we have option 2 and option 3, and we have to choose one of them. What do you think of pulmonary embolism? Is it acidosis, respiratory acidosis, or it's respiratory alkalosis? Is it acidosis or alkalosis? Now I'm going to go for a vote. You could go between 2 and 3 and answer, and I'll take a vote from you guys. Okay, let's see what you guys are saying. All right, Dr. Lina says acidosis. Dr. Adhikari says acidosis. Dr. Lamina says, Lunima says alkalosis. Dr. Sadat Azora says alkalosis. Dr. Shokat says acidosis. All right, you need to give me, and Dr. Nagma also says acidosis. Now you have to give me a reason why acidosis and why alkalosis. You have to give me a reason. We can't just do like, we can't just go hullabaloo and say, all right, this is acidosis or alkalosis. Definitely it's a respiratory problem, but it is alkalosis or acidosis. And if it is alkalosis, why? It's acidosis, why? You're learning from one another. We're not going to look at notes unless absolutely necessary. We'd be learning from one another through discussion, right? That's the whole aim of the class. Okay, so why an alkalosis? What happens as such in pulmonary embolism? Increased respiratory rate, right? Increased respiratory rate would lead to decreased carbon dioxide, respiratory alkalosis, respiratory distress, fast breathing, loss of carbon dioxide. Dr. Nori says that. So you're saying it's respiratory alkalosis. All right, let's go with Dr. Kamal's reply. Let's see if that is true. Yeah, that is 110%. Okay, this is a prompting a drop in arterial carbon dioxide partial causing alkalosis. You guys follow? Now, what is it here? What is it? Why is it alkalosis? Right? Voice is breaking. Is it better now? Can you guys hear properly? How about now? Is it better? Is it really need to continue? Okay, how about now? Is it better? Okay, right. So here's the thing: when there is hyper that you see when panic does the person have when you are ventilate during that time too, right? Can you guys hear me? Now, when a person is having a panic, okay, so can you guys hear me properly now? Is my voice clear? Okay, no voice, no screen. How about now? Is it better? Okay, can you guys hear me? Can you guys hear me right now? I'm hoping that you can. Right, no, it's not so better. How about now? I have changed my position. All right, that's great. So what I'm saying is that when a person has panic attack, right? When a person's having a panic attack, what happens to them? What happens to them? Do they start to hyperventilate? That's what they do, right? They do hyperventilate. When the person has a panic attack, they hyperventilate. When they have pulmonary embolism, they hyperventilate. And you're going to get readings on an EBG of respiratory alkalosis. And how do you differentiate? When a person has panic attack, the oxygen concentration is normal. However, in pulmonary embolism, the oxygen concentration also drops or deteriorates. Right, guys? Clear? Should we move to the next question? I'm hoping this has been clear somehow and you guys can still hear me and see the screen. Let's move to the next question. All right, okay. Now, again, we're going to always start by reading the end of the question, right? This one says, what is an absolute contraindication to thrombolysis, right? What is an absolute contraindication to thrombolysis? Now, what does thrombolysis mean? That we're trying to break off the clot, right? If you read the scenario, it says it's a 55-year-old female that presents to the emergency department with central crushing chest pain. An ECG taken on arrival shows ST elevation in lead 2, 3, and AVF, right? 2, 3, AVF. First of all, what kind of MI is it when the lead 2, 3, and AVF is involved? What kind of MI is it? Right? You have an inferior wall MI because 2, 3, and AVF are involved. So what is the contraindication for thrombolysis? What happens when you have a thrombolysis? What are we doing in thrombolysis? We try to break the clot. Okay, so what would be the contraindication of a thrombolysis? Known intracranial neoplasm, stroke 12 months ago, pre-proliferative diabetic retinopathy, menstruation, history of peptic ulcer disease. Neoplasm, stroke 12 months ago, pre-proliferative diabetic retinopathy, menstruation, history of peptic ulcer disease. Now, how do you use the technique of diagnosis of exclusion thing here, or the exclusion of options, right? Exclusion of options. For example, there are lots of people and they have history of peptic ulcer disease. Do you think if a person has peptic ulcer disease, they cannot do thrombolysis? Having peptic ulcer disease, does it make it difficult for them to go through thrombolysis? Yes or no? If a person, for example, a woman, she's menstruating, would you ask her to not go for thrombolysis? If somebody has pre-proliferative diabetic retinopathy, thrombolysis is going to do something to the diabetic retinopathy, or is it independent of that? Because this retinopathy is controlled by diabetes, right? Is stroke 12 months ago? What about stroke? Can a stroke be a reason for thrombolysis contraindication? Can stroke be a reason for a person having thrombolysis? Can that be a contraindication? If hemorrhagic. Okay, all right. Okay, now we have option 1 and 2. What do you choose? Known intracranial neoplasm. Okay, known intracranial neoplasm. You guys had said 1 earlier. Did you all say 1 earlier? Because if you did, I'm just going to choose that. Is it 3 or is it 1? You guys are saying it's a stroke, preproliferative diabetic retinopathy, known intracranial neoplasm. Which one do you think we should choose? 3? This one? 1? Okay. All right. Dr. Shaukat says 1. Dr. Leneva says 1. Dr. Pachan says 1. Dr. Sadia says 3. Okay. Dr. Samir says B. Anyone else has some say in it? Want to contribute? Why 1? Why not 2? We'll find out. We'll find out. So whoever says the next thing, I'll just choose their one. Yes. What do you think we should choose here? We have to go swiftly, Elliot. All right, you guys are saying 2. Most of you are saying 1, but because Dr. Zef has said 2, let's see if 2 is correct. It is incorrect. It's incorrect, right? 12 months ago is stroke. First of all, we don't know what kind of stroke it is, whether it's hemorrhagic or non-hemorrhagic, right? Then first we need to know that, right? And it's been 12 months ago. That means it's almost resolved, right? It's been a year. It must have resolved. Whilst local policies vary, an intracranial neoplasm is considered an absolute contraindication to thrombolysis, right? The other options are contraindicated, but these are relative contraindications, right? So having peptic ulcer disease, menstruation, preproliferative diabetic retinopathy, stroke, these are relative contraindications, right? Known intracranial neoplasm is an absolute contraindication. Let's read it here. Thrombolysis is the one which is going to, these are the drugs that are going to, these are going to help in dissolving the clot, right? We have alteplase, streptokinase, contraindications. Please take a screenshot of this. This was not clearly given in Plabable, though they would not ask it, but if they do, then it is really important, right? Intracranial neoplasm is stroke less than 3 months, right? Not 12 months, less than 3 months. Aortic dissection, recent head injury, pregnancy, severe hypertension, active internal bleeding, right? Because you see, when you're going to do thrombolysis, what would happen is that the clot would break off. And if there's an active internal bleeding, that'll make it bleed more, right? Recent hemorrhage, trauma, surgery, coagulation, and bleeding disorders, these are the contraindications. But it's an absolute contraindication to not having thrombolysis is an intracranial neoplasm, right? Let's move to the next question. Okay, let's move to question number 4, right? This one says, what's the most likely diagnosis? Now, this is a person, and these are his ABGs, okay? All right, they're saying that there's a 24-year-old Caucasian. Now, you see, when you have to read your respiratory profile, when you have to read your ABGs, I'll say there are 2 options for you to go. The first one is that you read the ABGs and get confused in it. The second one is see the presentation. All right, see the presentation, see how they have presented, right? So what's the most likely diagnosis you're asking, right? Before we're going to the options, let's see the presentation. This one says it's a 24-year-old Caucasian male. They're complaining of sudden onset of shortness of breath and a dry cough, okay? Caucasian, they have given us his oration too. Shortness of breath, dry cough. He's on the general ward and is 3 days post-operative surgery. His body mass is 36. Is he overweight? Or is he normal in his BMI? Is his BMI normal or is he overweight? Can you guys hear me still? Is he overweight or his BMI is normal? He is obese, right? He is obese, he's overweight and is still using PCA, patient-controlled analgesia for pain relief, right? So this person has been through a surgery, right? They have been through a surgery, they are overweight, they have a dry cough, they have a sudden onset. You see this word sudden onset, this is of grave importance, right? Sudden onset of shortness of breath, post-surgery, in a surgical ward, obese. Now, it seems like that this person might have a panic attack, right? Immobilization, as Dr. Samir says, immobilization. So it could be a panic attack, or it could be pulmonary embolism, because, post-surgical, immobilized, obese, these all are risk factors for pulmonary embolism. How do you confirm it? We just talked about it. We just looked at it. That if it is pulmonary embolism, it's supposed to be respiratory alkalosis. How do you confirm it? Look at the pH. Is pH on the acidotic side or on the basic side? pH is on the acidotic side or on the basic side. Let's go for references as well, right? Let's see what is the normal pH. Can you guys see the screen? I'm hoping you can, because I'm just moving forward. Is it basic or alkalotic? But first we'll also look at it, right? Just for those who don't know. Okay, because who have forgotten, right? Look at the pH here. Here, please to take a screenshot of this, because this is zero and flammable, but if you want to, you can. Right, look at the pH. The pH value is 7.3 to 3.5, 7.45. If it is more than 7.4, it's alkalotic. Less than 7.3, it's acidotic. Right? If the carbon dioxide is more than 6, it's acidotic. Less than 4, it's alkalotic. Right? Okay, PO2, this is a normal PO2. If this was a panic attack, the oxygen would be normal, right? That is, it would be between 10 to 14. Do remember that. These values are to be important to be remembered. I know that you're going to get a reference paper. They'll tell you all the values. But from now, from today onwards, start memorizing the values for, I know you would eventually remember them when you have your exam nearby, because you would have done so many questions by then. But from today, because this is a beginning of what we've started, right? So remember the values of your ABGs, which includes your pH, carbon dioxide, and oxygen, right? If you want to remember the base axis, you can, but I would just recommend carbon dioxide, pH, and oxygen. And remember your sodium, your potassium, and your urea, right? These are the basic molecules or the chemicals that you should remember the values of, right? So the pH you see here is alkalotic, all right? Okay, this is an alkalotic pH. What about oxygen? Is oxygen normal or is it low? Is oxygen normal or is it low? Is oxygen normal or is it low? Yes, guys, it's low, right? pH is alkalotic, oxygen is low, right? Now this only should make you think of what? This only should make you think of pulmonary embolism, right? This only should make you think of pulmonary embolism, because that is very, very common, right? Also the person's signs and symptoms, right? Let's just come on its signs and symptoms. This person had a shortness of breath, and what else did he have? He had dry cough, right? He was post-surgery, he was immobilized. Now, hospital-acquired pneumonia, should he have a fever? Does this person have a fever? This person does not have a fever. Pulmonary hypertension. Do we say any heart failures? We don't. Opiate toxicity while using his PCA. He is how many days post-operative? He's just 3 days post-operative. Kind of impossible. Obesity, hyperventilatory syndrome. He's short of breath, so he's hyperventilating, which is also incorrect. Do you guys understand? Are you guys following? Because if not, we can redo this. Do you guys understand? Are you following? Yeah, I do need some replies here. Okay, that is great, Dr. Hamza. Right, so pulmonary embolism is correct answer, right? Most likely this is correct, right? Pulmonary embolism. Let's move to the next question, because we're doing good, so I don't think we need to explain further. All right, okay. Now this one is for you guys. This one is for you guys. This one is for you guys. You guys have 30 seconds to answer this one. Even though you have just started and many of you might not even remember things, but just read the question and see if you can answer. All right, you guys have around 30 to 40 seconds for this. Always start by reading the question first. This one says, what's the most likely to be seen in the ECG finding? Yeah. All right, C. Okay, nice. You guys are saying 5. Now let's read for the rest of us. All right. This one says, what's the most likely to be seen on the ECG finding? This is a 65-year-old man. Okay, now here's the thing. You guys are saying 5. Let's see if 5 is correct. I'm just going to submit the answer. That is supposed to be true. That is right. That is correct. Now, how did we get here? See, This is a person who has, they're asking what would be in the ECG. He's 65, he underwent anterior MI, and he has a PCI, right, 5 days ago. Right, he had an MI 5 days ago. He now presents with pain. He lies down but feels relieved while leaning forward, right? So this most likely is pericarditis. You guys know that if there is an MI, there are going to be two kinds of problems which would be including pericarditis, right? The first one is pericarditis itself. The second one is Dressler syndrome. But if it was a Dressler syndrome, first of all, it would present after weeks. This has presented after 5 days, right? It has presented within days. Dressler syndrome presents within weeks. Whatever I'm saying is incredibly vital. This is exactly what you need to remember, right? 5 days, within 5 days after MI, think of pericarditis. Within 5 weeks or weeks after an MI, think of Dressler syndrome. But in Dressler syndrome, you have fever, right? You have other problems. And in addition to that, you have pericarditis. And if the person in Dressler syndrome and in pericarditis, the person is going to have saddle-shaped ST elevation. All right, saddle-shaped ST elevation. This topic was tested in the June 2020 exam, right? Okay, so post-MI Dressler syndrome is also part of pericarditis. This is saddle-shaped elevation, all right? Okay, all right, guys, I'm hoping you guys were following and understand. Let's move to the next question. Okay, now they're saying, I hope you guys are following, right? This one says, in the management, which condition is nicorandil most useful? What is nicorandil? What is nicorandil? Do you guys remember what is nicorandil? Anybody knows what is nicorandil? What kind of drug it is? Many of the things might feel foreign and you might not remember them, but do know that it would all come back to you. Nothing to be pressured about. Don't feel bad about it. If you don't remember things, that's all right. We're going to learn. We're here to learn. We're just starting. It's going to be good. Okay. So Dr. Nori Kawal says it's a potassium channel activator, right? It's a potential channel activator. Okay. Hypertensive, you're saying it's used in hypertension? Okay, so what should I go for? Heart failure, hypertension, angina, atrial fibrillation. If you're saying it's a potassium channel blocker, that's what you guys said, right? Most of you said it that it's a potassium channel activator. Dr. Nori said it's potassium channel activator. And what do we use it in? Nicorandil. Any wild guesses? Dr. Nori says 3. Angina, Dr. Hamza says 3 too. All right, let's see if that is true. Dr. Sadia says atrial fibrillation. This is not a recall. This is a high-yield topic. Nicorandil is, as Dr. Nori said, a potassium channel activator, which has a vasodilatory effect on the coronary arteries. Side effects include headache, flushing, anal ulceration. Very important that you remember this drug. Nicorandil, this is given as a treatment for angina pectoris, right? Okay, so how do you treat an angina pectoris? You're going to start off with your sublingual GTN. Aspirin and statin are prescribed unless there is a contraindication, right? Unless there's a contraindication, you can always give aspirin and statin. Otherwise, you're going to give a GTN, which is sublingual glycerol trinitrate, to abort the angina attacks, right? The first line, the ones that are going to help in an angina are beta blocker and calcium channel blockers, right? As it says over here, beta blockers and calcium channel blockers, right? In case a calcium channel blocker is used as immunotherapy, verapamil, diltiazem are used. If used in combination with the beta blocker, then use long-term calcium channel blockers such as dihydropyridine calcium channel blocker, right? What they're trying to say is that you could use either of them, right? To avoid the attack, we're going to use GTN, right? Then if you want to use a beta blocker or a calcium channel blocker, you can, but not together, right? However, if you're using it together, then you can use dihydropyridine combination with a beta blocker, which is nifedipine, right? What they're trying to say is that if you're using beta blocker with a calcium channel blocker, try using the modified release nifedipine. All right, as simple as that. Okay, now This is which is very, very important. Nitrate tolerance, just leave, let's leave that because it's too detailed, right? I'm just going to go for things which are essentially important for you to remember so that you would be able to solve your plavables too. All right, so avobridin, it is a new class of anti-anginal drugs which works by reducing the heart rate. Exon, the funny ion, right? Don't remember that, just remember some of the adverse effects, which is headache, bradycardia, visual effects, which is mostly, headache is also something that is associated with the rest of the common drugs. So what you need to remember here is that if the person has a stable angina, this is also, like you're training for your plab too. If a person has angina, you're going to start with lifestyle modification, medication, PCI, and surgery eventually. But for all the diseases where you can modify them, go for lifestyle modification. All right. Okay. Next question. I'm hoping you guys are following and understand what we're doing. If we are really fast, please let me know which slow down. Okay, but there are 296 questions and we're going to have alternate classes, right? Like today is Saturday. So then we'd have a class again on Monday, then on Wednesday. Okay, then again on Friday, then again Sunday, right? This is how it'd be going. We'd be doing alternative, right? Like leaving one day in between so that you could study on your own as well. All right. Okay, this one says, what is the single most likely condition associated with this kind of murmur, right? Now they're saying which condition or what is a diagnosis that is associated with this early diastolic murmur, all right? Okay, now how many murmurs are diastolic murmurs? Can you remember just one disease which has a diastolic murmur that you've been reading forever, that one disease that you've been reading forever with a diastolic murmur? Do you remember a disease which you've been reading forever and has a diastolic murmur? Mitral stenosis, right? Rheumatic heart failure, right? Mitral stenosis, okay? So mitral stenosis has a what? It has a diastolic murmur. Is it a late diastolic murmur or a mid diastolic murmur or an early diastolic murmur? Okay, it's a mid diastolic murmur. Now I'm gonna just try and draw something. I'm hoping you guys can see the screen. Okay, can you guys see the screen? Okay, let's draw. All right. So you see, you have got your systolic murmur, right? Then you have your diastolic murmur, right? So in diastolic murmur, you have to remember two, just two for the beginning, right? Just two. The first one is MS, right? With MS, you're going to think of A, all right? And because it is stenosis, here you would see regurgitation, right? So mitral stenosis, aortic regurgitation, these are diastolic murmurs, right? These are diastolic murmurs. Mitral stenosis is a mid or end diastolic murmur. Aortic regurgitation is an early diastolic murmur. And other diastolic murmur is PR, pulmonary regurgitation. Do you guys follow? I hope I'm saying the right thing, because if I go wrong, it's on you and you are supposed to correct me. Do you guys follow? Do you understand? So diastolic murmur has a mitral stenosis and aortic regurgitation and the pulmonary regurgitation, all right? Systolic murmur, on the other hand, has what? Which ones did we just learn right now? We did? Aortic stenosis, right? Pulmonary stenosis. Those were our ejection systolic murmurs, weren't they? Aortic stenosis and pulmonary stenosis. I'm hoping you guys can see the screen, right? Can you guys see the screen? Aortic stenosis and pulmonary stenosis were our ejection systolic murmurs, right? These are the ejection systolic murmurs. Can you think of other kinds of murmurs? Then we have our MR, TR, VST. Can you tell me what kind of murmurs are these? These are pensystolic, right? These are pensystolic murmurs, right? So MR, TR, VST, these are pensystolic murmurs. Then we also have mitral wall prolapse. We have a click here. We have a click here, okay? We have a click here. Is it a systolic click or a diastolic click? Mitral wall prolapse. Okay, all right. For now, just remember these. In diastolic murmurs, when you're thinking of the famous murmur, right, it's a diastolic one. Mitral wall prolapse is a diastolic murmur, right? Okay, here's the thing. When you're thinking of murmur, think of first the most famous murmur that you've been reading forever is of mitral stenosis, which is a diastolic, mid-diastolic murmur. All right. Then when you have been thinking of mitral stenosis, right? Then on the other hand, think of aortic, right? Because this is a stenosis, this is regurgitation. So aortic regurgitation is a diastolic murmur. Then you think of pulmonary regurgitation altogether. Then in systolic, you have aortic stenosis, pulmonary stenosis. Those are ejection systolic murmurs. And in your systolic murmurs, then you have your MR, TR, VSD. Those are your pensystolic murmurs. So we have an early diastolic murmur. We spoke about it. Which of the following do you think is going to have been, is going to be an early diastolic murmur? Mitral regurgitation is early diastolic murmur. Aortic regurgitation is early diastolic murmur. MVP on the chart, mitral valve prolapse. Mitral valve prolapse. MVP is mitral valve prolapse, which is a diastolic click, right? So we just learned that aortic regurgitation is early diastolic murmur. All right, and you guys are saying too. I'm not doing it because of me, because you guys said it, right? So this is your aortic regurgitation. All right, that is 110% correct. Let's move to the next question. All right, next question. This one says, what is the mechanism of action of alteplase? We just read this drug, right? Alteplase. Is it a thrombolytic? Is your alteplase a thrombolytic? Can you name at least 2 contraindications for thrombolysis? Can you type at least 2 contraindications for thrombolysis that we just read right now? All right, just 2. Okay, just 1. The one that we just read, a thrombolysis, absolute contraindication to thrombolysis, neoplasm. All right, we did say neoplasm. Another one? Okay, stroke, hypertension, neoplasm. All right, what else? What else? Active bleeding, right? Active bleeding, that's also contraindication. Now it is simple. All right, so alteplase, trauma, that is true. Trauma. Okay, now this trauma, right? Surgery, very right. So not trauma. What is the mechanism of action of alteplase? It activates thrombin to form thromboplastin, inhibits the conversion of fibrinogen to fibrin, inhibits plasmin, activates plasminogen to form plasmin. What is correct here? Inhibits the conversion of fibrinogen to fibrin. That's what Dr. Samir says. Inhibits the conversion of fibrinogen to fibrin. Yes. What is correct? Inhibits the conversion of fibrinogen to fibrin. Okay, should we go for B then, Dr. Samir? Any idea? Okay. Dr. Divya, Dr. Sheila, Dr. Safana, Dr. Bachchan are also saying too. Let's see if that is correct. We just did it. Activates plasminogen to plasmin. Right, when you inhibit the conversion of fibrinogen to fibrin, we have these drugs. Yeah, Dr. Yo is right. Dr. Yo, next time I would want you to, if you're joining these classes, then I would want you to definitely write your correct name. Right, here it is. So what it does is, how do these thrombolytics work? They work just, you have to write the following things. The first thing is write alteplase. The other drug name, write streptokinase, and in front of it write activate plasminogen to form plasmin. You are going to remember this. You're going to go through this again and again. We'll be doing lots of questions, and that's how you'd remember it, right? Plasminogen to plasmin. That is how these thrombolytic drugs work. All right, okay, next question. All right, guys, we're trying to move a little faster. We're slow today, but we're just starting off, okay? All right, they're saying, what is the mechanism of action of aspirin? I'm sure you guys know this one. What does aspirin do? How does aspirin work? The first option says inhibits the production of prostacyclin. Second one says glycoprotein 2B, 3A receptor antagonist. Then the third one says inhibits the production of prostaglandin H2, inhibits ADP binding to its platelets receptor, inhibits the production of thromboxane A2. What does an aspirin do? How does an aspirin work? How does an aspirin work? I'm sure you guys know this. All of you know this. I'm sure you do. And if you don't, that's all right. Just, just think about it, or go for an option, right? You guys are 25, and I want all of you to answer almost, right? Please do answer. Inhibits COX-1. Okay. All right, Dr. Yo. So 5, you guys are saying 5. See, right now this is a trial one, right? Most of you are just here for fun. But if you really are going to be in here, you all would have to answer, right? C, inhibits the production of thromboxane A2. That is as simple as that. Right now, this is the management of STMI, and we need to understand it, right? Even though we don't have an option at the moment for learning STMI, but right, we're not doing STMI, but we have to learn it. Now, when there is a person, I'm hoping you guys are following me throughout, right? If there is a person, very right, thromboxane A2, if there is a person, if my voice breaks off, or if you have problems with my connectivity, or my voice is not clear and you can't see the screen, please do tell me, because I'm not very sure what kind of signals or sentences you are receiving. I'm hoping you guys can hear me properly. Okay, so here's the thing. If a person has an MI, right, and they present to you within 12 hours of the onset of the symptoms, this is really important to be understood. If a person presents to you and they have an MI and they present within 12 hours of onset of the symptoms, right, you have to treat them within PCI or fibrinolysis if it is available within 120 minutes. Right? Understand. For example, there's a person and he was having symptoms of heart attack 6 hours ago, right? It started 6 hours ago. That means and when he came to the hospital, you can give them fibrinolysis within 120 minutes. 120 minutes is how much? 2 hours? How many hours is 120 minutes? How many hours is 120 minutes? Can you guys hear me still? How many hours is 120 minutes? 20 hours? 3 hours? 2 hours, right? It's 2 hours, 60 minutes in 1 hour. So if you can give them PCI or fibrinolysis within 2 hours, then you said to have given them primary PCI. Right? No. We're doctors, not mathematicians. I know we skipped mathematics because we wanted, we could have been in the CAs and accountancies and we could have earned more with less work. But we all hated maths. This is why we're doing this today, aren't we? Right? So don't worry about it, right? We're here. Okay. So that's okay. So here's the thing, Dr. Yo, that, if you can give them your PCI within 2 hours and they presented within 12 hours of the onset of the symptoms, right? For example, they had an MI at 3 p.m. and right now it's 6 p.m. That means that you can still give them a PCI within 120 hours if it's available. If not, if you cannot give them a PCI within 120 hours, then you're going to go for what? You're going to give them the basic management and we're going to give them the thrombolytics, right? Okay. If you cannot give them PCIs, then we can give them medication. All right. Okay. Do go for this. So if they're not already taken an anticoagulant, then we can give them Pericarditis and aspirin. Okay, but this is for an STMI. We're going to go in a little bit of detail, but first let's talk about PCI. Then when would we give them PCI? PCI given within 120 minutes. In case patient's ECG is taken in 90 minutes after fibrinolysis and there is no ST elevation, then they would still require PCI. Okay, according to the British Thoracic Society, 94% more than 94% oxygen saturations are to be maintained. We're going to give them sublingual glycerin trinitrate, morphine, metoclopramide, aspirin, right? Unless it is absolutely contraindicated, we're going to give them that. All right, and PCI is to be given. All right. The people who are having primary PCI, they'll be given prasugrel and aspirin if they are taking PCI. All right. Or if they are on already another anticoagulant, then we can give them clopidogrel and aspirin. This is more simplified and plabable. It is more detailed here. But what I'm trying to tell you here is that, if you have a person and they have had an MI within 12 hours, right now there could be another person and they're going to have an MI, but they woke up in the morning and they had been having pain, right, like from last night, but they woke up and they had heart attack, right? So if you remember the time from that time, good. If they do not, then we're going to think about giving them a PCR or not, right? Okay, now one more thing you need to remember is that that, you know, NSTMI is different, treatment is different because we do not have an ST elevation. What do we give if there is an NSTMI? We give aspirin, nitrates, antithrombin treatment, which is your fondaparinux, right? And angiography is done within 24 hours of patient's creatinine. All right, do take a screenshot if you want. These notes are not there in Plabable, but they are more simplified there. Okay, cardiology, we're starting with this one because it is one of the toughest. And I think that a lot of people have problem in understanding cardiology. I myself had. So, right, so for NSTMI, this is NICE 2020. This is a new one. They say all patients should receive aspirin, 300 milligrams, nitrate and morphine to relieve chest pain, antithrombin treatment, fondaparinux. Angiography is done within 24 hours of the patient's creatinine. Coronary angiography is performed as soon as the patient is, you know, possibly in patients who are clinically unstable. That's when you go for coronary angiography. Otherwise, you try and treat them with medications. Now, this one is to be absolutely taken in account by you, and you should take a screenshot of this because we just did 2 or 3 questions of this sort, right? We just did 2. Right? Okay. So aspirin inhibits the production of thromboxane A2. We just did it. Clopidogrel inhibits the ADP binding to its platelate receptor. Enoxaparin, right, activates antithrombin 3, which in turn potentiates the inhibition of coagulation factor 10A, right? Fondaparinux activates antithrombin 3, which in turn potentiates the inhibition of coagulation factors 10A. All right, this is getting boring. Just take a screenshot and then you need to memorize it. All right, let's move to the next question. Okay, let's move to the next question. All right, this one says, what is the single most appropriate management for this patient? All right, what is the single most appropriate management for this patient? All right, okay, so they're saying what's the management? Now, he has not had any symptoms since then. Now, when you read that the sentence above the question is vague or it doesn't give any clue about the patient's symptoms or conditions, what do? You move immediately to the beginning of the question. Do you guys follow what I'm trying to say? What I'm trying to say is, if you read the question, right? If you read the question and after that you move to the question, to the sentence above the question, and they don't give anything properly or, you know, any information in that, you move to the beginning. So let's read from the beginning now. A 69-year-old gentleman presents to the GP's clinic. He gives a history of 4 days ago noticing left-sided facial drooping, which he noticed in the mirror, right? So 4 days ago, this person had left-sided facial drooping. He did not do anything about it that time and was pleased to see that it resolved spontaneously around 40 minutes. What do we do right now? So this person had a what? He had facial drooping 4 days ago and it went away on its own. This is known as transient ischemic attack. No? Isn't it? It's a TIA. Dr. Sadia is right. It's a TIA, right? You guys follow? That he had a problem 4 days ago and it resolved on its own. So this was his transient ischemic attack. Right now, what do we do? All right, should we give him aspirin and urgent referral to the specialist service? Clopidogrel and an urgent referral to a specialist service. Clopidogrel and urgent referral to referral to specialist service. Just give him aspirin. No pharmacological therapy needed. You guys would tell me, what should we do? What should we do in this situation? Right, see, a treatment for TIA that has been resolved. No idea, that's all right. We're just learning, right? We've just started to learn. If you don't have any idea, that's all right too. But I would absolutely want you to do, you know, just click any option, think about any option and do type it. Because what happens then is, when you do such a thing, what happens then is that you're activating your brain centers to remember that you had got this wrong. And when you think that you got this wrong, the next time when you do it, you're going to try and get this right. Okay? All right. So any option that comes your way, do talk about it. Any option. Okay. So you guys are saying one, aspirin. All right, aspirins to be given. Let's see if that is correct. That is right. You're going to give them C. A patient who presents to the GP within 7 days of a clinically suspected transient ischemic attack, right? A person who comes within 7 days of a suspected TIA, as this person had, they should be immediately given aspirin, 300 milligrams, right? This is really, really important. And be referred within 24 hours to a specialist review, right? Because if a person has it in a TIA, there's a chance that he's going to get a full-fledged stroke in some time soon, right? NICE guideline recommends patients who have clinically suspected TIA should be loaded on aspirin immediately and referred within 24 hours, right? This is really important, and that's all you need to remember, all right? Okay, that if a person has a TIA and it's been around 7 days, they should be referred to the specialist service within 24 hours with a loading dose of 300 milligram of aspirin, right? This is what you need to remember. Moving to the next question. Okay, right. Okay, this one says, what is the most appropriate next step in the management? All right. Okay, a 74-year-old female presents to the emergency department following a fall at home. All right, now we read the first sentence. Now, what I want us to do is that either we read the first sentence or let's again move from the thin below up. Okay, so given the likely diagnosis, they're saying you already know the diagnosis. What's the most appropriate next step in the management? Let's read the sentence above it. It says, a 12-lead ECG is performed, shows narrow QRS complexes, variable RR intervals, absent P waves at a rate of 150 beats per minute. What do you think this is? Okay, they're saying that you know the diagnosis. Now we're going to also do ECG. So let's just do a ECG, right? Just read. Okay, this is AFib for sure. You guys know it. All right, this is AFib. Now, okay, you guys said it's AFib. I'm going to teach ACG as well for the ones who've just started as we move ahead. But for now, you guys have said it's an AFib. Okay, now if you know this is an AFib, when you're treating a person with AFib, do you look at the age, right? Not necessarily, Dr. Farah, you're right, but not necessarily. If it's an older person, right? Okay, we're going to do ECG, Dr. Haskam, don't worry. Like related to what is important for your plab one, right? So if it's an older person and we're doing their ECG, right? And if they're having atrial fibrillation, right? For older persons with atrial fibrillation, we give rate controlling drugs, right? Rate controlling drugs such as a beta blocker, right? Do hear me out. You guys might be right, but you need to hear me out. If a person is vitally stable, right? Vitally stable, meaning their blood pressure is fine, their heart rate is fine, the temperature is fine, the saturation is fine, right? Okay. We are going to treat their AFib depending on the age, if they are vitally stable. If they are old, above 60, then we're going to give them rate controlling drugs. If they are younger, then we go for pharmacological cardioversion, right? Pharmacological cardioversion. Digoxin, doctor, is given when the person has heart failure along with atrial fibrillation. If they do not have heart failure along with atrial fibrillation, if they are older and they just have atrial fibrillation, then the rate controlling drug is a beta blocker, right? Then the rate controlling drug is a beta blocker, as Dr. Bachchan says, right? But if they are younger, they have atrial fibrillation, they are vitally fine, then we're going to give them cardioversions, which is pharmacological, right? That is clear. Now let's look at this person's vitals, right? Now you don't need to read the whole thing. If you want to, you can, right? Because you're just starting. All right, okay. 74-year-old female presents to the emergency department following a fall at home. She failed, she's unconscious, right? Can you tell me one heart condition, one heart valve condition where a person would come as unconscious and they're old and they've fallen? Most likely, most common in UK, we just spoke about it. One heart, aortic stenosis, right? Aortic stenosis, a person fail at home, right? Unconscious, very old, aortic stenosis. Most likely this person is having aortic stenosis. Aortic stenosis is mostly associated with atrial fibrillation, not necessarily, mostly, right? Mostly, most of the cases, right? Okay, so this person has fallen at home. They are having PP, which is, they're having an absent BP, their RR is variable, their heart rate is kind of high. Look at the vitals. Are her vitals stable? 8152, is she hypotensive or is she fine? 8152, is she hypotensive or not? She is hypotensive, right? So if she is hypotensive, okay, you're confused, all right? Okay, this is hypotensive, right? Okay, now if this person is hypotensive, right, 8152, right, 8060, right, okay, 8040, when a person has vitals like that, which are, you know, like kind of low, maybe anemic, yeah, maybe, but we're not going for maybes here, right? She's also unconscious, right? No, Dr. Haskam, what I said was, if they were vitally stable, now you see, this person is not vitally stable. If they are vitally stable, then age plays a role in treatment for atrial fibrillation. If they are vitally stable, if they're vitally unstable, we don't care about the age. If we're thinking it's atrial fibrillation, we go for immediate DC cardioversion, right? Do you follow what I said? That you're vitally unstable, we only treat them depending on, if they're vitally unstable, we don't look at the age and we directly treat them with immediate DC cardioversion, right? Okay, Dr. Noreen is right. That less than 90 is hypotensive. Okay, next question. Right, next questions maybe around 20, and then we'll take a break. Okay, all right. Now, again, this is for you guys. You guys have 30 seconds to read the question and answer. Thromboprophylaxis and DC cardioversion. See, that person, Dr. Hina, you're right, that is a good question, but this person was vitally unstable, right? This person was vitally unstable. We could go for thromboprophylaxis, but there is no use of thromboprophylaxis here, right? We need to save this person. They come to the emergency, they're vitally unstable, right? They're vitally unstable, they come to the emergency, we really have to treat them immediately right now. Okay, so you guys have 40 seconds to answer for this one. All of you are supposed to answer because I'm looking at you and I'm seeing who's replying and who's not. Okay, you guys have 40 seconds for this. Okay, I am sorry, I don't know what I did. Yeah. All right, okay. All right, that's good. You guys are saying MR. Let's see if MR is correct. Can't hear because I am talking. All right, so it's MR. I'm hoping you can hear me right now. That is true. Now let's read it. Right, this one says, what's the most likely cardiac defect this patient has? She doesn't smoke, she doesn't drink alcohol, right? Now you see, when they're talking about defects of the heart, the answer is going to be somewhere here on the auscultation side, not on the beginning of the symptoms. That is, she presented, she cannot lie down flat, she has basal crepitations, fine, sure, she's having a heart failure, but your answer is lying somewhere in the last sentences, right? Okay, auscultation of the heart reveals a 2 grade 6 pensystolic murmur. Can you guys tell me which are the 3 conditions when you have a pensystolic murmur? Pensystolic murmur, 3 conditions. MR, TR, VSD, right? She's 55, unlikely to have a VSD, all right? Unlikely to have a VSD. She's 55. Could be, but VSD is mostly in, children and people who are teenagers or 20s, not in the 50s or 60s, right? So VSD is out of the window, right? Then the second most common is MR, right? If we had TR, fine, we could have said that. We do have that, but here is the thing. Here is the thing. She is 55, all right? MR is at apex. That's also true. That's also true. See, pensystolic murmur is going to come around like that, right? Okay. Where is our clue? Our clue is in the question that why did we choose an MR? 55 with struggle to lie down flat. She has widespread bibasilar crepitations on auscultation and irregular radial pulse on examination. Past medical history is significant for anterior lateral myocardial infarction. Do you see that? MI. MI is going to lead to mitral regurgitation, right? Eventually, okay, all right. So eventually, MI would lead to mitral regurgitation. This is why first our answer. All right, guys, is that clear? Yeah, can you see it? Because we have to do other questions, so I don't think I'll be able to just show you then. Can you hear this? Can you see this? Sorry, can you see this? This is a question, yeah? Whenever you say, I'll move to the next one. Okay? Should I move to the next one? All right. Okay, I'm hoping. All right, okay. Now this one says, what's the single most vital step regarding anticoagulation? Right? Okay, what do you do regarding anticoagulation? Now, they're saying 77, okay? 77 presents for review. He was recently admitted for atrial fibrillation. This was his second episode of atrial fibrillation. He also takes ramipril for hypertension, but has no history of note. During admission, he was given apesiban and discharged with planned follow-up in the cardiology clinic. However, on review today, he's found to be in sinus rhythm. Right? So he was given apesiban and discharged with plain cardiology, plain follow-up in the cardiology. They're saying, what do we do regarding anticoagulation? Right now, he's having sinus rhythm. When he came in, he had atrial fibrillation and he has been discharged on apesiban. Should we continue for 6 months? Should we continue lifelong? Should we stop and start warfarin? Should we continue apesiban for 1 month? Should we stop apesiban? He is in sinus rhythm because he's taken the drug, isn't it? He is in sinus rhythm because he's taken the drug. If you stop the drug, he would not be in sinus rhythm because atrial fibrillation does not cure, right? Do you guys think that asthma is curable? Hypertension, diabetes, are those treatable or curable? What's the difference between being cured and treated? So if you have flu, you can cure it, right? If you have a cut on your skin, the new skin comes in and the cut is gone. That is a cure, right? Treatable meaning that they cannot be, like they don't come back. They may come back, right? They are there. They are not eradicated from the root. For example, cancer, it's not curable, it's treatable, right? Atrial fibrillation, not curable, treatable, right? Continue lifelong apesiban. That is right. These are DOACs. We continue them lifelong because if we do not, then they are not going to be in sinus rhythm, right? Very clever answer and good. Okay. Okay. All right. Now for this, I want you to remember a chart. Okay, here's the thing. They're saying, what is the next best step in the management of this patient? There's a 12-month-old boy. Bronchial transplant, Dr. Yo, once you do that, then we'll think about it. We'll run some research and see if that is possible. Yeah, but it's too expensive, no? Just to cure one person's asthma. Okay, a lot of work. And we're trying to go for little work here. Okay, because we do a lot of work anyway. Okay, a 12-month-old boy during a routine, thank you, Dr. Yo. So 12-month-old boy during a routine vaccination develops a rash and breathing difficulties. On examination, he's developing swelling around the mouth and neck. What is the next best step in the management of this patient, right? So the ones who are not answering, this is for you, because I'm sure you guys are like, this is the first time and I don't know if we're doing right and if we remember anything or not. Don't worry, this is why we're doing it, right? Okay, so here's the thing. He's 12 months old, right? And he's having anaphylaxis, isn't it? What is happening here? What's the diagnosis before you go for 4, 1, 2, or 3? What's the diagnosis? Is it kind of an anaphylaxis, right? With this person developing swelling around the mouth and neck. What's the next best step in management? Nebulize? No. Phone 999 reassure mother, we don't do that. Right? During routine vaccination, he developed anaphylaxis, right? So we have to give him IM adrenaline. Now we need to decide how much to give him. and that depends on the age of the person, right? So you guys saying 4, we try and remember that. Okay, how do we remember that? Here is the chart on how we remember that. Okay, here is the thing. If the person is below the age of 6 years, please remember it. If the person is below the age of 6 years, right, they're below the age of 6 years, then 150 micrograms. They're below the age of 6 years, then 150 micrograms. If they are above the age of 6 years and in between 6 to 12 years, below the age of 6 years, 150 micrograms of adrenaline. Below the age of 6 years, no. Below the age of 6 years. Below the age of 6 years, 150 micrograms. Above the age of 6 years, or between 6 and 12 years, 300 micrograms. Above 12 years, 500 micrograms. I'm repeating it. Below 6 years, 150. Between 6 to 12 years, 300. Above 12 years, 500 micrograms. Right? Below 6 years, 150. Between 6 to 12 years, 300. Above 12 years, 500. You got to remember it like that, otherwise you'd forget it. I'm sure you guys remember it, the ones who do, right? But those who don't, this is for you. And we give it an IM on the anterior thigh, right side, because that is the exposed area, right? In the middle third of the thigh, right? The anterior lateral aspect of the middle third of the thigh, because that's the best side for injection as it is exposed, right? Again, below the age of 6 years, 150 micrograms, which is 0.15 ml in 100,000, right? Over here, if you can see, 0.15 ml, 1 in 100,000. That is below the age of 6 years. Between the age of 6 to 12, 0.3, which is 300 microgram, right? Above the age of 12, 500 micrograms, which is 0.5 ml in 1,000. All right, guys, is that clear? Should we move to the next question? Right? Okay, I'm hoping this is fine. Let's move to the next question. Okay. Today we're going slow because we're trying to learn things, right? Tomorrow, inshallah, not tomorrow, day after tomorrow, we'll be picking up the pace. Okay, let's do this. Right, this one says, what's the most likely diagnosis? All right, now this is time when we learn the ECG. Okay, I'm just going to share this here. All right, now when you're looking at the ECG in your plab 1, this is your P wave. I know you guys know it, but I got to tell you here. All right, for the ones who don't know, this is your P wave. After P wave, what do you have? You have your R wave, right? Then you have your Q. I think this is a very weird ECG, right? So this is your P, this is your QR, S, and this is T, right? So for your ECGs, you have to first locate your P wave, all right? You have to first look at your P wave. If you find a P wave, right, then you have to calculate the PR interval. All right, this is Q, this is your R, PR interval. That's the next thing. All right. If you locate the PR interval, if it is more than 0.2%, then it is your first degree heart block, but it's going to be a constant one, right? Then it is your first degree heart block, which is a constant one. All right. If the PR interval is above, right? If the PR interval is above 0.2, then it is your first degree heart block, right, guys? That is your first degree heart block. If your PR interval, right? Now we're learning the second type of heart block, which is second degree heart block. It has got 2 types in it, which is Mobitz type 1, Mobitz type 2. I hope you guys are following. Are you all following? I hope it's not too much information, right? Okay. When it's second degree heart block, then it's got Mobitz type 1 and type 2. In that, what happens is that your PR interval is constant, right? PR interval is constant, all right? In Mobitz type 1, in Mobitz type 1, it keeps on increasing, right? It keeps on increasing. It keeps on increasing on and on. It keeps on increasing, right? It keeps on increasing. It keeps on increasing. Then suddenly what happens is